next presenting company is Cirrus Health. Cirrus Health has an electronic discharge system to improve doctor-patient communications. And presenting this morning for Cirrus Health will be Thomas Thornton. Tom.
Great. Thank you, Neil. Now for something completely different. Cirrus Health is an early-stage healthcare information technology company. We're a spin-out of the Feinstein, as you heard earlier. Our first product affects a point of patient care that likely every single person in this room has suffered through, and that is discharge. If you, as a patient or a caregiver or a loved one, has been discharged, you've likely experienced the extraordinary inefficiencies and the points of confusion around discharge. We're developing a product to automate that, to enhance patient engagement and to improve provider performance around that. Why is this important? As healthcare systems transition from volume-based care and fee-for-service to value-based care and being paid for outcomes, they are scouting for, searching for transitions of care platforms like ours that can help manage that process. We are as I said, spun out of the Feinstein. Our two investors at this point are the Cleveland Clinic and NSLIJ. They've invested $500,000 to date. They are more than investors. They're fantastic partners. We have used them as a sandbox, so to speak, developing the enterprise architecture, the form, features, and functions of our product. And perhaps even more importantly, the usability and the workflows associated with the product itself. The two organizations have committed for paid pilots at their respective institutions. We'll get that done in the summer of this year, and we'll look to use the use cases associated with that to make the product available for commercial sale in 2015. We're also executing and finalizing our go-to-market strategy and looking to finalize a distribution channel agreement as we speak. The founders are Dr. Dave Langer and Ken Court, one of those crazy physicians that is perpetually looking to change things and realizes just how broken discharge is, not just for his own practice, but for his patients, and an IT expert. I joined when the Cleveland Clinic and NSLIJ formed Cirrus Health. My experience, about 20 plus years in early stage investing and working with early stage companies. This is our competition, and I can tell you our competition is pathetic. The vast majority of discharge instructions are paper-based, be it out of an acute care hospital or an ED. It takes an extraordinary amount of time to develop these things. They're provided in the final seconds or minutes of your stay at the hospital. They're not personalized. They're extraordinarily confusing. You lose it on the way to the car. It's just, we can do a lot better, I think, is the point here. This is the discharge process. It is confusing. There's no surprise there. I'm going to peel out a few numbers here, though. 76% of patients that leave the hospital are unsure what to do next. What's my next meeting? Who was my doctor? What just happened to me? What's the blue pill? It's just awful. 50%, no surprise, don't even understand the discharge instructions that were provided to them. And mind you, again, in this paper-based system. Unfortunately, some of that confusion can lead to readmission. That's a big deal. Big deal for the patient, financial penalty to us as we, again, move toward this outcomes-based payment model, and this is why the product is so important. We solve the problem in really 5 ways. One is we enable best practices associated with discharge in our product. Upon admission, not upon the last 20 seconds of your stay, but upon admission, workflow lights up, effectively creating an orderly and efficient discharge process. 2, we, instead of telling you what to do in the instructions, we actually begin the patient education process in the hospital. 3, we make it actually personal to your unique circumstances. If you have a wound, we're going to teach you how to care for the wound. We're going to videotape it, and you can actually take that with you, and I'll show you what that means in a second. Next, we're going to give you a sense of how you want to consume this kind of media. Right now, it's all paper. You want it in paper, that's fine. If you want it sent to a patient portal, that's fine. You want it sent to your mobile phone through an app, that's the kind of functionality that we think is critically important. It's also important because we want to create a care circle around the patient. Increasingly, we're seeing this as a really killer way to address patient self-care after they leave the hospital. Lastly, is to incorporate all of this into the EMR. This is a wireframe of our product. Obviously, you can see certain features of it, but really, if we had a video in there, you get the video. This is actually the web version, the HTML version of our product. There'll also be a mobile component to it as well. We have taken some time, of course, using the experience of our partners, NSLIJ and the Cleveland Clinic, to take a look at what would this product look like and what's the value inside a discrete hospital and the entirety of our healthcare system. This is what it looks like at Lenox Hill. Value-based payment and readmissions, that's clearly a penalty that I've already mentioned, and something that gets bigger and bigger over time as we move toward value-based care. Follow-up and compliance is actually revenue capture and recapture, so a pickup, if you know what I mean, in terms of revenue opportunities, and then obviously the productivity associated with the terrible inefficiencies within discharge. Our market size is large, 35 million discharges in the United States. That's just the United States. We can model the rest of the world if you'd like us to, but it is extremely large. $6 billion market opportunity, most of that associated with discharges, but also attendant productivity and overutilization issues associated with poor discharge as well. We have a quadrant pricing model, really effectively two products, so a full-blown acute product for acute care, a lighter version for outpatient and emergency departments, and then a pricing that is tiered according to discharges and beds in those two separate settings. Our go-to-market strategy, of course, let's use our partners, Cleveland Clinic and NSLIJ, adopt the product, obviously using the use cases from the implementation of those two organizations to drive sales, not just within our affiliated networks, NSLIJ by example, 17 hospitals in our system, but 35 affiliate hospitals outside of our system. The ability to push it out into that network is certainly a key strategy. And obviously looking to close on a distribution channel partner as well. Projections here, clearly early wins with the clinic and NSLIJ. Obviously choosing to invest a pretty substantial amount into product development and marketing as we see this transition to value-based payments. Certainly something we want to stay on top of. Our use of proceeds, our goal here is to raise about 500, 750. Use of proceeds is associated with further development, sales, marketing, things of that sort. And let me just close in saying that we're an early stage company. We're fortunate to have two extraordinary partners, and the trend we're riding, most importantly, is this transition from volume to value. Thank you.
Questions? Steve?
How far have you gotten in turning these ideas into actual business with the clinics?
So we're, great question. We're about a third through the build right now. We are on track to have the beta version done in June.
How about the business side of the relationship? Have they agreed to signing up, but these the rates?
Yeah, that signed up, those are the rates, and we're in the final stages of negotiating our strategic distribution channel partner relationship. That one will probably be a month or two away.
How do you integrate with all the disparate systems in the network already?
Yeah, great question. So Cleveland Clinic has a single EMR. Believe it or not, North Shore LHA has 14. So clearly connectivity is a very big deal. In fact, that's the complexity of it. We effectively have to develop, to answer your question specifically, we effectively have to develop connectors for every single EMR. To be candid, that is a challenge, but nonetheless, that's the way we're going to do it. I think we're fortunate that we're using those two systems. One again with a single EMR, us with a very complex, disparate EMR network. Most of the connectors for most of the major EMRs will be done as part of the beta build.
Will you be able to replicate that then?
We absolutely will. Build it once and you're done. If there's something fortunate to us, there are probably 5 top EMR vendors. We will clearly build to those 5, but to be very clear, there certainly are others, and we'll have to customize that if in fact you're not one of the top projects.
Last question.
What are your barriers to entry? If you say another competitor wants to replicate your process, how difficult are they?
It's a great question. So as a part of this, which we really didn't get into, there's a certain element of this which is data analytics. We actually want to provide data and analytics back to healthcare systems for process improvement. We want to be able to predict whether or not a patient may actually be readmitted into a healthcare system. That kind of stuff certainly prevents some barrier. In all candor, I think at this point our secret sauce is the relationship with the Cleveland Clinic and NSLIJ. That sort of use case, the traction we can get, the data we can get around the implementation, at least at this point, is key.